be a point in the presentation where Mr. Walsh will show some surgery. He's going to warn you before that's shown on screen. So if you'd rather step away from your screen at that time, you will have that opportunity to do so. So let me introduce our esteemed speaker, Mr. Daniel Walsh. Mr. Walsh is a leading consultant neurosurgeon who is based at King's College Hospital in London. He specialises in complex surgeries on the brain, spinal cord. He has an international reputation as an expert in diseases of the blood vessels affecting the brain or spinal cord, including cavernoma. So I'm now going to stop talking. I'm going to hand over to Mr. Walsh to say hello. And thank you ever so much, Mr. Walsh, for joining us today.
Not at all. Thank you very much for having me back. So once again, thank you for inviting me back. And as you said, I'm a neurosurgeon who specializes mostly in blood vessel problems in the nervous system. I work in London. At the top of the talk, I did want to warn you that because I'm a surgeon, I have this pathological need to show pictures of the human body whenever I can to people, and that's because I think it's marvelous. But you might not wish to see it. I will try to remember when there's a picture coming up. It's in the second half of the talk, if there is. So just be aware of that if it distresses you. The other thing I really need to make clear is that talks like this and question and answer sessions are not a substitute for a medical opinion and cannot be. So I can't really give you direct medical advice about your individual condition, but I'm sort of happy to talk about pretty well anything in general terms. And I have no conflicts of interest that I can identify related to this talk. So when we talk about cavernomas in the central nervous system, we broadly break them up into three groups. Those in the brain, those in what we call the brain stem and deep nuclei, and those in the spinal cord. If you happen to have a spinal cord cavernoma, you are part of a very exclusive club because it's the rarest of the three, and it's a rare condition. It was first noted in pathological specimens in 1903, and the first successful surgical removal was reported as far back as 1912. But more than 100 years later, we're still not entirely certain how prevalent they are within the normal, well, healthy population. We have an idea that if you have a spinal cord cavernoma, there's probably a 10 to 40% chance you'll harbor a brain cavernoma. But there's really very little data on them other than to say that they're about 5 to 12% of all spinal vascular malformations, which is itself a rare disease. One thing that is generally accepted is they tend to be more commonly found in people who have familial cavernomas. That is to say, people who have a genetic driver causing them to form cavernomas, usually more than one, and those may be passed from generation to generation. This paper here is from 2020 and was a reasonably large study of over nearly 300 patients with familial CCM1. For those of you who know what that is, it's one of the genes that we associate with cavernomas forming. And in fact, in this cohort, the prevalence of spinal cord cavernomas was 70%. But other even larger studies have suggested it may be closer to about 10%. If you can bear with me, I'm going to spend a bit of time talking about just the spinal cord itself and trying to explain how it works because it's a very complex organ. When one understands a little bit about how it works, it gets a little bit easier to understand how symptoms arise through injury of that structure. And that injury may be injury that's visited on it by the cavernoma through bleeding, or injury visited on it by attempts to remove the cavernoma surgically. And I will tell you what we currently know about treatment for spinal cavernomas. So When we talk about the spine, perhaps the picture that first comes into a person's mind is this bony column that runs up our central axis, that's mobile, and it's made up of lots of little bony building blocks called vertebra. And from the sides emerge, and the illustration there, you'll see these yellow lines emerging, which are the nerves forming off the spinal cord and transmitting right throughout the body. The spinal column itself protects the spinal cord, and each of these vertebrae have little orifices within them. And at the center, the central one transmits the spinal cord up and down. The spinal cord itself is, if you like, an extension of the brain stem. So we've got the brain up here. I've done some radical surgery and removed all this gentleman's bones. And the brain stem ends about here, and it continues on as a tail down to the lower thoracic levels when the spinal cord stops and is replaced by a leash of nerves that we call the horse's tail, or the cauda equina. But as you can see, at every level, there are nerves coming off and transmitting right throughout the body. Mostly, the spinal cord is made up of nerves that are en route somewhere else to meet with another nerve. But there are collections of what we call nerve cell bodies even within the spinal cord. So it has some autonomous control centers of its own. And a couple of examples would be some of the sensation to your face is integrated within this part of the spinal cord up here. Down around here, there are reflex control centers for bladder function and sensation. So there's a lot going on in there. The way we generally talk about the nervous system being organized is we think of the brain and the spinal cord as being the central nervous system, and then the things that emerge from them, either cranial nerves up here or peripheral nerves from the spinal cord. A nerve cell, which is making up these structures, is typically made up of a cell body, which houses a number of organs within the cell that allow it to do its job and to live. So it has energy centers called mitochondria. It has little packets of chemicals like calcium and sodium that, by being allowed to leak through the walls of the cell, generate localized electrical currents. And those electrical currents act as messengers to be transmitted along to other nerves. There's usually a larger process emerging from the cell here called the axon. These smaller ones that allow it to communicate with cells nearby are called dendrites, so-called, named after branches of a tree. And they come in different configurations. You can have the cell bodies halfway down an axon, or you can have relatively short axons, depending on what the job of the nerve cell is. When these nerve cells talk to each other, they do so at junctions called synapses. And within the synapse, you have, again, these little packages of chemicals that can be released into the space and activate receptors on the surface of the next nerve. And the chemicals that transmit these messages are called neurotransmitters. Some of the best ones the best known ones are ones that are affected by medicines, for example, in the case of depression, monoamine oxide inhibitors or serotonin reuptake inhibitors have proven to be very effective treatments for that. And there's a vast list of different types of chemicals that have been identified that play roles in transmitting messages between different kinds of nerves. So these nerves are talking to each other all the time electrochemically. By the time we get out to the peripheral nervous system, it's become a little bit like your broadband network at home. And there are multifunctional cables, which are the peripheral nerves. Think of each axon being gathered together into a group we call a fascicle, then multiples of these fascicles being bundled together to form the nerve. This obviously is an illustration, but here you actually have a real picture with some stain on it to show the individual little nerve axons within the fascicle cuts head on, the cross section of it. Different nerves cells have different jobs, and depending on how they are insulated and their physical makeup, some will transmit information on pain, some will be to activate motor function. They all have different vulnerabilities and strengths as a result of that. So we'll get back into that in a moment. There is even an example of where one of these nerves pretty well ends in a chemical reservoir that allows the emission of a chemical messenger directly into the blood. And that is your adrenal gland. Adrenaline and noradrenaline are neurotransmitters. So the adrenal gland is a little gland that sits on top of the kidneys, and it is connected directly to the spinal cord and the central nervous system. And when the message arrives from the nerves, the adrenal gland, rather than being released to communicate with another nerve, the adrenaline is released directly into the bloodstream. And that triggers what's sometimes called a fight or flight reaction. It's part of your automatic survival instinct when you're threatened or under stress. And that brings us to the third part of this system. Apart from the central and the peripheral nervous system, we have something called the autonomic nervous system, which is in the background. And this is the system that's operating and keeping things ticking over in the body. It's generating the heartbeat regularly and regulating it. It's allowing muscles and blood vessels to relax and contract to change size and shape, which affects your blood pressure, which might be necessary to ensure blood flow, for example, to an organ stays the same whether you're lying down or standing up. And pretty well any of the organs in your body will be reached by the autonomic nervous system, but it will not operate under voluntary control for the most part. If we take away the organs, you can see that it constitutes a separate network all through the body. And on the left here, I've just shown you some of the organs that are regulated by it. It's worth talking a little bit about the circuitry that these nerves go together to make. Perhaps at its simplest, there's a thing called a reflex circuit, where, for example, when I tap on your knee in the course of an examination, what I'm actually doing is I'm changing the length of a muscle fiber in this muscle. And this is transmitted back to the spinal cord, where through these circuits, another nerve is activated that tells a muscle that's responsible for the opposite reaction to what this nerve does. If this one shortens, this one lengthens, and we get a reflex jerk at its crudest. And so you're made up of layers and layers of muscles that are constantly activated. If the nervous system was not there, these muscles would simply lie there flaccid. But in fact, you maintain something called muscle tone. So there's a constant state of contraction, which is usually resisted by a complementary set of muscles that react and relax in response to contraction to what's called the agonists. So agonists and antagonists. If the bicep muscle contracts, the tricep muscle relaxes to allow smooth movement of the joint here. All of that is under constant regulation by messages being passed down the spinal cord from the brain. There is a tendency, the basic arrangement is that the muscles at the front here, the ones who want to contract, tend to predominate if left to their own devices. So there is a constant message coming from the brain saying, relax, relax, relax. If that's lost, then we see an increase in tone in the muscles. And that's something you may have experienced yourself, or you may have seen in others who have suffered any form of injury to the spinal cord or even higher up in the brain. When a really serious injury occurs to the spinal cord very suddenly, initially all contact is cut off and the muscles um, do become suddenly flaccid. We call that sometimes spinal shock when it affects the autonomic system. So the muscle tone in the blood vessels, for example, can become lost, causing the blood pressure to fall, or the heart rate to be difficult to regulate. And in the immediate period, if at its worst, if somebody has been paralyzed, the limbs will be very, very relaxed and flaccid. But within days, one will begin to see the return of reflexes, partly in response to injured nerve cells releasing chemical messengers that they've stored in the injured nerves and getting into that space, causing activation of nerves downstream. As the weeks go by, the nerves may try to regrow, and that's a mixed blessing sometimes because they have a limited capacity to heal themselves back to their starting position, and they may grow in a disordered way that results in excessive activation of the peripheral nerves, and one may then see the establishment of what's called spasticity, which is pathologically elevated tone, exaggerated reflexes, and even the forcing of the extremities into uncomfortable postures because of the dominance of that tendency for the muscles to contract. Later on as well, these messengers may start to broadcast messages to the brain that the nerve is in distress. Even though the injury may be long gone, these messages are perceived as pain, typically a burning pain that's very difficult to it doesn't respond well to medication or the conventional painkillers that one uses. We call that neuropathic pain, which is a very distressing symptom. Back to the normal function of the spinal cord. One of the really important things being transmitted through it is sensation. And there are different types of sensation. There is touch, what we call fine touch or coarse touch, pain sensation. These are all distinguished in the type of nerves that transmit them. There's information about how long muscle cells are and where the extremities are in space. That sort of information is usually transmitted in to the spinal cord and then travels up to the brain via the brainstem to the brain, on crossing over at the brainstem level, but through groups of nerves at the back of the spinal cord called the dorsal columns. The pain fibers, though, for example, would come into the spinal cord and then immediately go across to the other side for the most part, and then ascend. There's a small number that remain on the same side as well, but most will then travel up to the brain on the opposite side of the spinal cord, which helps one understand why one gets loss of feeling on one side compared to another, depending on the type of lesion that's being caused. And you'll see here in the drawing on the left, you can broadly map which segments of the spinal cord are delivering the sensation to the brain from different parts of the body. So these green areas all start in this, what are called the sacral segments of the spinal cord, so the very bottom and the cauda equina, in fact. Blue, we're moving up into the lumbar segments, and then we follow the segments up through the thoracic, the cervical, and into the brain itself, where the trigeminal nerve is giving sensation from the face. Movement is a complicated arrangement as well, I'm afraid, with broadly two systems. There's something called the pyramidal tract that's responsible for most of the voluntary movements that you make with your muscles. And that signal begins in the brain, then travels down at the front of the brain stem and the front of the spinal cord before going out on the opposite sides to the effector muscle that we're trying to activate. On top of that, we also have motor systems that are involved with involuntary control of things like balance, locomotion, posture, and tone. And those are all traveling up through various different groups of nerves. We call those tracts within the spinal cord. So if you haven't got a headache already, the reason I'm telling you all of that is When we look at the spinal cord in cross-section, and remember, we're looking at something that is roughly the thickness of your little finger. All of those tracks, groups of nerves traveling in different directions, up, down, and across, are all packed into that space. And this is a rough summary of how it is laid out. So the red tracts here are the ones that are traveling down from the brain to the periphery. The blue tracts are information coming into the spinal cord and then being transmitted up to the brain. And if you notice, we are pretty limited. If for some reason we have to enter into this organ, there's very little opportunity to make a surgical incision in this without cutting across some of those really important messages. Now, the two most commonly used routes, if we do need to do surgery within the spinal cord, would be either to go between the dorsal columns at the back of the spinal cord that carry information about coordination, position, and so on, or depending on the type of lesion we're looking at and maybe what level in the spinal cord it is or what problems the person maybe already has to deal with. We will sometimes use this space, which is called the DRES, or the dorsal root entry zone, which is where the sensory nerves tend to enter the spinal cord or just behind it. And there's a natural, very tiny plane of cleavage there that allows an opening relatively safely. Now, at this point, I'm just going to remind you, I may be about to show you some pictures of real spinal cords and real surgery. So bear that in mind. This is somebody's spinal cord, which we're looking at. This is a very swollen spinal cord because something is going on within it. But the surface of the spinal cord looks broadly normal. And all of those white structures that you can see and those blood vessels running across are functional. They're transmitting messages, and any disturbance of them will cause problems. So how do you find out where you can separate between these dorsal columns? The technique I'm using here is using a thing called video angiography, which is something we use in vascular neurosurgery a lot, but not typically for cavernomas. But you'll see what it does allow you to do is map out the blood vessels on the surface of the spinal cord. And if you allow it to run long enough, you'll see there's this very straight line running straight up the middle, which is what we call a raphe. And that represents a sort of the plane of cleavage that I'm looking for between the two dorsal columns. And I can relate that to what I see here. The other thing one can do is one can get an electrical tool and stimulate or map where the dorsal columns are, and a technician in the operating room will say, yes, you're on dorsal column there, you're on left side of it, right side of it, or maybe you're not there at all. But almost as important is taking time to just look really, really carefully, look for evidence of peripheral nerves beginning from the spinal cord, which the trained eye will just make out here, but I'll show you easier to discern ones in a moment, and then working out precisely where halfway is. If you can identify that plane of cleavage, then it is in fact possible to gently separate the two without, as you can see here, even there really being a great deal of bleeding or any need to pass electrical currents through the tissue. We're just using a very sharp knife or a diamond blade. We can open the lining on the most superficial part and then tease apart the spinal cord using diamond dusted instruments. Here's a video which the main reason I'm going to show you is just to illustrate when you show people still photographs, it's often forgotten that we're frequently operating on moving targets. So this is a dorsal root entry zone myelotomy, and we're making that just beside where the nerves are coming out of the back of the cord. Notice though how the cord itself moves. That's with every breath the patient is taking, every heartbeat. And the structure you're looking at here is maybe 5 millimeters across. So it's very fine work that requires a bit of patience to minimize the trauma that we visit on the spinal cord, but we definitely do visit some trauma, however careful we are in reaching these lesions. We try and get early warning if we're causing too much disturbance by monitoring electrical messages passed down through the spinal cord, sending little electrical signals through scalp electrodes down into the periphery where they're recorded by a technician nearby. And also we can place an electrode, as seen here and here, directly on the spinal cord. And that will allow us to look for a response to stimulation called a delta wave or a D wave, which is a good marker of how well the motor nerves are working. It's very sensitive to any damage to movement, and as long as you can keep that above 50% of its baseline, any weakness that is encountered postoperatively is highly likely to recover. So that's very useful information if you're trying to tease something away from them. Here I have a picture of a cavernoma that's completely contained within the cord. So we can only reach this by identifying where it is, first of all, with ultrasound scans here up at the top right. And then I use all that other technology to help locate the ideal spot to make the minimum opening to allow me to tease away the cavernoma itself. Sometimes the cavernoma will present to the surface of the spinal cord, and you can see it. But even then, you have to respect those anatomical boundaries, because you'll notice there are even little tiny flecks of tissue running across the clear abnormality here, but even those could represent nerves with a degree of function. So you respect those boundaries, open them up in the same way, and then you find at the end you're able to reconstruct the spinal cord to something close to normality again. This is a similar problem. The cavernoma is pointing up right in the middle. So on the one hand, you might think, well, this is easier, but you still have to work out exactly where the middle is if you want to minimize the trauma to the spinal cord. And ultrasound, again, is very, very handy in just working out exactly how long any incision needs to be to get all the way around the cavernoma, and then find exactly the midline to split these tissues apart so that we can see the cavernoma beneath, deliver it out, and then reconstruct the cord using microsutures that are thinner than a human hair. So the surgery is you know, it's a challenge to do. It's nice to do, but does it pay off? And with very rare diseases, you're always asking yourself, well, what are the results of the surgery, or any potential damage I might cause, any worse than the risks that the disease poses? And here we have a problem, because, as I said, those of you with spinal cavernomas are in an exclusive club. There was an attempt to synthesize all the published literature of any quality in 2014, and worldwide only 631 patients were identified. Now, those authors came up with an estimated risk of hemorrhage from a cavernoma in the spinal cord then of about 2% per annum. You have to take that with a grain of salt, because these are retrospective studies, and also there's probably something called selection bias, because the vast majority of people in the literature have had treatment. Very few have had conservative treatment. So it's possible there are people living with cavernomas who are asymptomatic and don't know it. So this might be an exaggeration brought about by the fact we're following only people who already have symptoms. For what it's worth, the authors felt that the surgical intervention was generally justified on the basis that the rates of worsening were broadly similar whether you left them alone or operated on them. And of course, the ambition of surgery is to try and prevent any further deterioration in the long term beyond surgery. They found the best results were when the surgery was done within 3 months of the onset of symptoms, probably related to the fact it doesn't allow much time for scar to form around the lesion. And they preferred an approach which has been usual for me for many years now, called hemilaminectomy, which is a relatively less invasive way of entering the spinal canal. Asim Kiddu and colleagues have brought this up to date more recently and have managed to assemble more than 1,000 patients now, coming up with a range estimated hemorrhage rate of 2.4 to 8% per annum. Again, only a tiny proportion, in fact, almost as few as in the original system analysis, were treated conservatively. So this is mostly data about people who have surgery. What we can say from it is that we're really bad at recording these cases. There's no real consistency with the type of disability scores that are used. But when we compare between the conservatives and the surgical groups here, we can at least say that broadly these seem to have been comparable groups for the most part. Not all the conservative patients, though, had any data on disability recorded. So we lost nearly half of those in the process, which would have been valuable to know. But here's basically the summary of that analysis. And what they found was that the top bar here are people shortly after their surgery. And most people, as you see, are either better or no worse than they were before the surgery. And this red bar represents the proportion, the percentage that are getting worse. Over time, more people move into the improved group, and the amount who are permanently worse is about half those who are originally worse off after the surgery. However, in the conservative group, which I remind you is much, much smaller, the proportions, I would say, are probably about comparable. So they concluded the same. Surgical intervention was justified in symptomatic patients, and they also found that if it was done within 3 months, the results tended to be better. So I'm going to finish off by saying that these are rare lesions. You knew that. They're more common in familial cavernoma syndromes. And if you do have a spinal cavernoma, it is probably worthwhile to check for brain cavernoma as well. Not because that's necessarily going to be more dangerous, it's usually not, but it may point you towards a genetic driver as a reason for the cavernomas, and that may be something you want to know about. Reports of treated lesions are what inform the medical literature. We're not at all as confident of what happens when you leave these things untreated, but most people are identified when they develop symptoms. That limits the quality of the recommendation that can be made about treatment. But based on the literature we have, for people with symptoms from a cavernoma, one that has bled, then surgery within 3 months might well be justifiable. But if they are asymptomatic, well, we really don't know the optimal manage. So one probably wants to be very conservative in that circumstance. Okay, so that brings me to the end of my talk, and it will be over to you for any questions.
Thank you so much, Mr. Walsh. And something I was really struck by was when you said there the spinal cord is roughly the size of a finger, and you just think then the skill needed in terms of the surgery and the complexity of that. I think you've really brought that to life. So thank you so much for that comprehensive overview. So I know you've had a couple of questions that have been put to you in advance, and you've got some slides. So let's begin then. And we've already got 12 questions in the chat. So once we've gone through those questions in advance, I'll take you through the ones that have come up in the chat.
Okay, I'll have a drink of water then. So one of the questions that came in ahead of the talk was not specifically related to spinal cord cavernomas, but it related to whether it was safe to participate in contact sport. And as you can imagine, that's a question we get asked a lot. Now, although it's commonly advised to get medical advice about whether to participate in such sport, in truth, any expert can only be an expert if they have evidence to inform their opinion. That evidence might be their own experience, it might be other people's experience. And the more of it they can refer to, the more confident they can be in the advice they're given. The difficulty with cavernomas in sports is we really do not have data that tells us you need to avoid contact sports if you happen to have a cavernoma, but neither do we have data that tells us it's perfectly safe to do so. And if one looks at it from the perspective as, say, a sports organization or the insurer of your local village hall that might be hosting your kickboxing club, um, might look at it. They regard any lesion, any structural lesion within the brain that might be at any risk of causing brain hemorrhage as a potential risk that they're exposed to. The rather busy slide I've put up here is really, I can almost summarize the data on this in cavernoma in 3 slides. That's how little there is, and most of it's quite recent. This is a survey of mostly American neurosurgeons, not exclusively, on the advice they give following particular sports inquiries. If an individual has a brain injury of any sort, and that includes structural vascular lesions. If you look down this column here, you'll see that in most of the cases that they were presented with are in single figures per sport. Being the United States, they only have one rugby inquiry, but I would get one rugby inquiry every month, more or less, in the UK. And one of the interesting things they found is that in recent years, the surgeons have tended to be more permissive in encouraging people to participate in sport because there's lots of benefits to doing so, psychological as well as physical. And the way I often put it is if you're being asked to live with a condition, then we should allow you to live with the condition, unless we've got good evidence you're going to be safer by absenting yourself from an activity. And what they found was actually the more elite the sports person was, the more likely they were to have a prolonged absence from their sport of choice. So you were far more likely to say it's okay for somebody to return to American football at school level than you were at collegiate level, which is the middle bar, or professional level. Which is interesting because one might have thought that the professional athlete would have more invested in the in taking the risk than the amateur athlete might do. So there was an effort to talk through the conversation that one has with a group of experts, well-informed neurosurgeons and neurologists in the British Journal of Sports Medicine in 2009, using cavernoma as an example. And you can read the paper; it's 2 or 3 pages long. But ultimately, it comes down to that the experts agreed that the footballer in question could be allowed to return to the contact sport. But there was no evidence to direct that decision. It was motivated purely by a willingness and a wish to allow the person to get on with their normal life in the absence of evidence to the contrary. But you can see the editorial comment here. It must be stated this is not necessarily a universal opinion, and a valid alternative view can also be proffered against returning to contact sport. And that's the problem we have. The literature does not provide us with sufficient evidence to state the absolute risk of hemorrhage or seizures in athletes participating in contact sport, but it's safe to state that the risk is greater than 0. So can anybody, therefore, if you like, give permission to participate in contact sports? I think, as I said, there are lots of advantages to doing so, and my personal preference is not to try and put things in the way. Just this year, there has been a case report of a French semi-professional rugby player documenting their journey back to playing rugby from an occipital cavernoma, having a craniotomy to remove it, and then being signed off to play rugby again. The mere fact that one case going through that journey merits a case report in the sports medicine literature tells you how little evidence there is to help us direct people on this journey. And I will say that the fact that they've resumed playing is wonderful, but I hope it continues, because the reality is sport is becoming more and more risk adverse, whether at professional level or amateur level. Because in hindsight, if there is evidence of a brain injury, they stand to be exposed to a great deal of financial risk through retrospective compensation claims. So I think most specialists in this area would want somebody who's living with a cavernoma where the risks are documented to be as low as they possibly can be, or else they might be considering treatment to lower them to the same level. But can we give a complete absolution? I think that gets more and more difficult every day, unfortunately. So I hope that goes some way to addressing that question, and maybe more explaining why you might be having trouble getting a straight answer from people as to say, yeah, do it or don't do it.
No, Mr. Walsh, that's very comprehensive, and it's a question we often get asked on the inquiry line, particularly from parents of children participating in sport. And I think you've put forward a really balanced view, and something I'm reflecting on was there's an opportunity for us to update our information on our website to help people take that informed decision. So thank you ever so much. So since you've been talking, we're now up to 21 questions. So
My second question.
I'll read through the questions and I'll take your lead at the point where you need to finish, and I'm going to take them in the order they've come. So the first one is, I have a residual cavernoma with an adjacent cyst at C3/4. Due to the tight space in the spinal cord, there's three parts of the question, can subtle changes of the cyst or cavernoma, not readily seen on an MRI scan, cause an increase in symptoms, e.g. neuropathic pain? Could these subtle changes include scarring as time goes on? And what is the relevance of a cyst with a cavernoma, including cerebral ones? And if you'd like me to repeat that, please do say.
No, that's fine. So the first thing to say is a cyst, which when we say cyst, we're talking usually about a fluid-filled cavity that is lined with a wall of cells. And those cells are either generated by the disease or they're part of the normal anatomy of the tissue that the disease process is contained within. Now, a cyst is not a characteristic element of a cavernoma, by and large. Sometimes you will see imaging reports refer to what might be a cyst, and what they're describing is in fact a cavern. So an element of the cavernoma, one of the little berries within it that is larger than the others, more prominent, and mimics the appearances of a cyst, albeit containing blood products. If it's not that, then usually an adjacent cyst will reflect previous hemorrhage, and it might well reflect a type of scar that has developed within the cord in response to that hemorrhage. One will occasionally see the normal, there's a tiny channel running up the center of the spinal cord called the central canal. If there's bleeding or a mass lesion within the cord, that will sometimes become obstructed, and the local flow of fluid within the spinal cord, because again, when you saw that video of the spinal cord moving, when that door is closed and I'm not in there operating, that is bathed in cerebrospinal fluid, which looks like water. That water doesn't just flow around the spinal cord, but it manages to find its way into the center as well. So there's a fluid dynamic exchange going on through the cord all the time. If that's interrupted, you can get a trapping of fluid that manifests as a cyst. And if it's the normal channel that's dilating, then we sometimes call that a syrinx. Now, any of those dilatations can result in the things you describe. They may be the result of scarring, and then they may play a role in the generation of something like neuropathic pain, which I talked about a little bit during my presentation. Does that mean if the cyst was not there, that the neuropathic pain would not be there? No, unfortunately, it doesn't. Sometimes decompressing a cyst or getting rid of it can help if growth in the cyst is clearly associated with worsening symptoms. But when you operate on anything that's a scar, nature will try and heal what you've just operated on, and more scar will result. So there is a risk of making matters worse as well. So it's quite a complicated question, which will be the real answer to which is going to be informed by your imaging, your physical exam, and your history. But I hope that gives you a sense of broadly what you might be looking at there.
Thank you, Daniel. So I'm going to go through the next question. I have an 11 millimeter cavernoma located in my corpus callosum. Apparently, this accounts for 0.01%, so a rare location. I can't find any information anywhere on what my possible symptoms would be or risks. They go on to say, as far as I know, I've had no bleeds, although I've not been since 2018, but I have lots of headaches, constantly dizzy all day long. Could you point me where I could find out more information? Basically, this person's struggling to find anything about this.
Well, I mean, the ideal link here is to say the Cavernoma Alliance is a pretty good place to start. I'm going to bring an assistant in, if I may, for a moment. Hopefully you can see them. And when we talk about the corpus callosum, we're talking about this structure here at the center of the brain, which is a white matter structure, which connects the two hemispheres of the brain, allows them to communicate. So it's broken up into different subunits, the front bit, the middle bit, and the back bit, all of which transmit nerves to and fro with different functions depending where one is. The most sensitive that allow things like coordination of movement and with visual stimulus are located at the back here. At the front, it can tolerate more manipulation or injury, but it's linked to some very important structures deep down that are part of the circuits that, for example, lay down memory. So what it isn't in terms of causing symptoms is not located, if it's in the corpus callosum, it's generally not located in gray matter, which is where typically one would be exposed to risk of seizures. And the risk from a corpus callosum cavernoma it's probably not completely correct to think of it as a lobar cavernoma, but we tend to think of it in similar terms to the risk from lobar cavernomas. So as I say, we broadly break it into the hemispheres, the deep nuclei, and the spinal cord. And the corpus callosum is probably on the verge of the deep nuclei. So the risk for most people is going to be relatively low in absolute terms if you've not had a hemorrhage. So it may be as low as 0.5% per annum. And in the event, depending on where it's located in the corpus callosum, any bleeding from it, which will often be very small amounts of bleeding, might be very well tolerated. So don't be distressed excessively about this. There is information out there, and there are people out there you can absolutely talk through with it. And there are options to treat them as well, if it's appropriate. But it's there's a wealth of information, as I said, on the Cavernoma Alliance and the Angioma Alliance websites that will be pertinent to you. But for most people, this is likely to behave in a relatively benign way.
Thank you for sharing that, Mr. Walsh. I can imagine those statistics are reassuring to the person who's raised it. And as you said, we also offer monthly online support groups, counselling. So please do get in touch if we can help in any further. So next question. If you have a cavernoma in the brainstem, will this affect your spinal cord? For example, a wobbly gait?
Yeah, so as you saw in the talk, the spinal cord is essentially a continuation of the brainstem. So all the information that enables you to walk normally without a wobble is passing through those structures. So depending on where in the brainstem exactly the cavernoma is located or where it might have injured, yeah, it's quite possible for it to affect your gait. you need more than just strength in your muscles to be able to walk straight. You also need constant information being broadcast to your brain telling you where in space your feet, your legs are. You need constant information about the lengths of the muscles to allow you to coordinate movements together. And all of that, as you saw, and referring back to my slides, has to travel up via the brain stem from the spinal cord, and the messages back from the brain go back down through the same route or close to it. So yeah, it's entirely possible that an appropriately situated brainstem cavernoma could affect balance and gait.
Thank you. So next question. I have a cavernoma at C3, but I've been told that is an anterior and inoperable. Is this the case? And what additional challenges can I expect?
So most cavernomas tend to be located in the cord dorsal to the equator of the cord, if that makes any sense. So most of them tend to be located towards the back. A minority are situated anterior, but if it's usually not a case that it's inoperable, but the risks of surgery might be sufficiently considerable that you wouldn't want to entertain them. Most cavernomas at the front of the cord are probably most safely approached from the back of the cord. So even if you need to travel a little deeper into the cord, that's the best way to do it, because there's too many sensitive structures surrounding it at the front for entry from the front or the side to be safer. It's probably not, not inoperable, but that doesn't necessarily mean it would be desirable to you to have it operated upon. As at C3, one of the risks a person would fear, or you would have to be told about, is what I tend to call neurological catastrophe. And while it's not the most likely outcome of a surgery, it's the one that perhaps most profoundly changes the quality of a person's life short of death itself. At C3, you could affect the ability to ventilate yourself, to breathe. Your breathing muscles might be made weaker. Your sensation in the face can even be affected, as I said, as well as all the other structures passing down that operate your arms and legs. So in the nightmare scenario, one could find oneself unable to breathe independently and also unable to move the arms and legs. Now, while that is not the most common outcome of surgery to remove a lesion in that area, it is definitely one of the risks, and maybe what's informing that advice.
Lovely. Thank you very much. So next question. What can cause a cavernoma to shrink on its own without treatment?
This happens all the time. I often describe cavernomas as a little bit like, imagine you had a bubbling hot bucket of tar or lava, and you've got bubbles blowing up and collapsing. So that's what happens. The little fruit that we always. I'm sure I showed you a picture of some fruit in my talk. It's almost the law to do so, but in fact, it's a bit more dynamic than that. The bubbles get bigger, and sometimes they collapse, releasing small amounts of blood into the tissue around them. So it is not at all unusual to see changes on cavernomas and serial scans. In fact, that is one of the reasons I don't recommend routinely scanning cavernomas if a patient is well, because it doesn't help you determine how it's going to behave in the future if these changes aren't associated with symptoms. They're not a brain tumor. They're not going to stereotypically, if they get bigger, they're not necessarily going to stereotypically get larger and larger. They may, in fact, get smaller without warning. And without wanting to breach any confidentialities, the most dramatic example of that I encountered recently was during the CARE trial, which you may know about. And I'd recruited a gentleman who had a very large cavernoma, and he had been suffering with dreadful headaches for years that we really hadn't been able to help him with. And I was persuaded that the size of this cavernoma, the mass of it, might be enough to be causing the headaches. And therefore, it was worth calling it symptomatic and considering surgery to remove it. And so this cavernoma, to begin with, was probably the size of a satsuma. And we did a scan on the morning of surgery for the surgical sat nav, and the thing had shrunk to 10% of that size, all on its own, and to a point where I couldn't possibly lay the blame for the headache at the door of that mass. So my advice to him was, I think nature has just given us a lesson here. This is not likely to be the cause of the headaches. And there, if I take that little thing out, I really wouldn't expect you to have a change in your symptoms. So it absolutely can happen. It happens all the time.
Gosh, and that's quite an extraordinary example to illustrate that. Thank you for putting that into context. So the next question, my 10-year-old daughter has a spinal cavernoma that's bled. This was removed. Is she at any greater risk of getting another spinal cavernoma? This was not hereditary, as the family have been tested.
Okay, well, that's good news that it's not hereditary, because that would be one's first thought. I imagine they have also done a scan of the brain. And I think given she's so young, it would probably be desirable to look again when her nervous system matures. Our nervous system is maturing up until the age of about 22. So at the very least, I would probably opt to look again at that stage to be certain. But bear in mind, the genes that we know about might not be the only genes that there are that drive cavernomas to develop. So while I think it's you can be as reassured as you possibly can be if you've checked for those genes. And I think all that would be required now is to allow enough time to go by to just look again one more time when she's more mature. And if there's still nothing there, I think we could all begin to believe that that was not going to happen again. But spinal cord cavernomas are much more frequently, as you saw in my talk, associated with multiplicity of cavernomas and genetic drivers.
Thank you. And Mr. Walsh, we're coming up to 8:30 and there's some more questions. How much more time can you allow for those questions to give me a sense of how many more to go through?
How much can your audience stand?
I think quite a lot. We've had really good engagement tonight, so I think everyone's very keen, and I'm getting some lovely positive messages. People finding it incredibly informative. So thank you. It's very generous of you to give your time tonight. So the next question. I have a T10/12 spinal cord injury due to cavernoma bleed 25 years ago, and I'm paralysed from the waist down. I was 22 weeks pregnant at the time. I've since found out I have brain and brainstem cavernomas through CCM2. My daughter, now aged 26, has the same CCM2 and confirmed brain cavernomas. We do not know if she has spine cavernomas, but she is about to go through genetic IVF. Does she have a risk of spinal cavernoma bleed with a higher risk?
So is the risk of the cavernoma bleeding higher because there's a genetic driver? There is some evidence that suggests one of the CCM genes is associated with a slightly higher risk of bleeding. But that increase in risk in absolute terms might be relatively low. So I think one has to be a little bit careful. I think about assuming that it's going to be an excessive elevation of risk, but it's possible. And I would need to just check, or maybe she could check with her clinical genetics counselor what the particular mutation was that she had and whether it's associated with a higher risk. But even those studies that have shown higher risk are relatively small numbers of people with a very rare condition associated with a very rare molecular abnormality. So it's never a prediction of the future. It's an estimate.
Thank you. So next question, would the pons be included in the spinal cord? So would the presentation webinar apply to a cavernoma in the pons?
No, the pons is part of the brain stem. It's one of you've got three parts to the brain stem. You've got the midbrain, which is at the center of the brain. Then you have, I've got my assistant again. I should maybe keep him with me here. But if you can see that, the pons is this nice round part to the brain stem here. It's so called because when you cut it across and look up as you would say in a CT scan, it's supposed to resemble a Venetian bridge, pont. And then that continues down as the medulla, and then the medulla becomes the spinal cord. So no, brainstem cavernoma.
Thank you. So another question related to the pons. What symptoms would you see typically in a symptomatic pons-based cavernoma?
It really depends on where it's located. You could have no symptoms whatsoever. If it intrudes, so at the back of the pons here, there's a little space running down the center here, which is where the cerebrospinal fluid flows. This area here is called the fourth ventricle. That thin layer of fourth ventricle is home to a number of vitally important structures that, starting from top to bottom, coordinate the movements of the eyes together, allow facial movement, allow facial sensation higher up, and also you have fibers that are not too far away that are transmitting to the medulla that are involved in movement and the coordination of movement. So depending on precisely where the cavernoma is and its size and the local structures it disturbs, there's a vast range of possible symptoms ranging from nothing at all through to double vision, headaches, difficulty with bright lights, hyperacusis, noisiness, sensitivity to noise, for example, balance problems. I could go on and on.
Thank you. So next question, please could you address the non-surgical reduction of hemosiderin and other interventions in order to reduce neurotoxicity of the residue? And I think some people may need a little bit of an explanation of what that all means for those so familiar.
And what you really need is probably a chemist as well, rather than me. But the problem with hemosiderin is iron that has been wrapped in protein by your body. That happened because there was some bleeding and blood was deposited on the nerve cells in the brain. Iron is very toxic to nerve cells, so the body reacted by wrapping it in protein. And that protein plus iron compound shows up in an MRI as the dark halo that you see around a cavernoma. We call that hemosiderin. Siderosis is what happens when iron is embedded in tissues. So you will sometimes, if you go on my website, you'll see a picture of a brainstem cavernoma being operated on, and you got these little berries, and they're surrounded by golden tissue. That tissue should be lily white. It's golden because the tissues contain a lot of iron. So the presence of iron in nervous tissue can cause it to malfunction. And there is a condition called superficial siderosis, whereby the continuous leakages of small amount of blood into the fluid that bathes the brain, which wherever it comes from, it could be a cavernoma, gets deposited, for example, on the hearing nerves, on the various that we call these folia in the cerebellum. Sorry, I'm hiding my assistant again, but the cerebellum here may get covered in iron, and that may lead to things like balance disorders, loss of hearing, or even dementias. Now, there has been interest for many years in using chemical agents, medicines, to try and sequester the iron from the tissues or from the fluid to reduce its impact on nervous structures. Something called there's a disease called Wilson's disease, which is a disease of the metabolism of iron. And I'm getting well out of my neurosurgeonal comfort zone in talking about it, but the agents that we're often trying to use for that to try and mitigate the effects of this buildup of iron will be called chelating agents. So molecules that grab the iron molecules and put them away somewhere safe, a little bit like hemosiderin does in the body. To the best of my knowledge, there has not been a lot of success with medical attempts to mitigate the neurological consequences of superficial siderosis. It probably has not been any better. Probably the most effective treatment has been if you can identify where the source of the bleeding has been coming from, that's your best opportunity to modify how the disease is going to behave in the future. But even that, the damage may already be done to a degree. But say you had I don't know, a hematoma or a tumor or something that was leaking blood somewhere in the nervous system, and you could take that away, that might, at least in theory, mitigate how the siderosis would behave in the future. Thankfully, the consequences of iron deposition in the nervous system seem to affect a minority of people. So I see folks who've had brain hemorrhages of all sorts all the time with evidence of iron sequestration in their nervous system who are basically well. So it is probably the minority of people who suffer from the most severe versions of this, and for whom those treatments are sought and directed.
And I think that's so important, isn't it, to know that it's the minority and to put that into context as people understand these risks. So thank you for clarifying that. And we do like your assistant. It helps to bring this conversation to life. So thank you to your assistant. So the next question, Mr. Walsh, thank you so much for this lecture. It looks like 11% are worse off after surgery. What proportion of the 11% have a serious morbidity, for example, full paralysis, ventilator, etc.?
I can't really tell you that from the data because of the way it's collected and described. Sorry about that. Within that group of operated patients are people with cavernomas at different levels within the spinal cord, who are, as you saw from I was interested in the pre-treatment data on disability, because that sometimes gives you a little bit of a clue as to whether there is a selection bias in the way it's being reported by choosing to operate on people who are in better condition neurologically because they are likely to tolerate the surgery better. But by the same score, it is equal. Some people will select to operate on people who are in extremis because you've got less to lose. You're likely to make things less, a bad situation worse. So it's really difficult to say. It's safe to say that the authors were reporting that as a good outcome. And within that 11% who were worse, there was a similar proportion worse who were just living with the disease. So that's comparable. But the individual, at the individual level, that worsening could have completely different consequences. So if you are living with neuropathic pain, but very little else in terms of disability, that might have a more profound effect on your day-to-day than, for example, an established motor weakness that you adapted to by using things like orthoses or some sort of physical support and made lifestyle adjustments that allowed you to live an independent life. So the quality of the disability and the impact of the individual is very difficult to talk on. And I think really we can only have those conversations on a case-by-case basis with people and say that here's what I think is most likely to affect you after surgery. I will say, with rare diseases, and you saw from the series presented that nearly all of these series are at most double-digit numbers of patients. So we all struggle to refer to our own experience. The danger is if it's going well for you, you're only one case away from somebody having a disaster. But I will say, I have seen examples of folks having early rebleeds after bleeding from spinal cavernomas that have certainly moved me a little bit towards being a bit more aggressive. If somebody comes to me with a spinal cord cavernoma than say I might be with a brainstem or brain one.
Thank you. And yeah, it's such a challenge, isn't it, with rare conditions when the figures are so low to be able to draw those conclusions. So next questions, a couple of parts to it. So first one is about any correlation known between cavernomas and gynecological challenges. And also they say I've got a minimal discussion regarding bulging discs and mild scoliosis. So would you advise a full spinal and brain MRI?
So if I understood correctly there, the gynecological problems.
Yeah, so and yeah, so I'm a little unclear myself, but I think what they're saying is they've got a history of gynecological issues and they've got spinal cavernomas. So they're wondering if there could be a correlation between those gynecological issues and their spinal cavernoma. And I think they're also asking, it appears they've got a bulging discs and mild scoliosis and wondering about the necessity of an MRI.
So it's very difficult to answer because the nature of the problem really tells you whether it's likely to be neurological. A gynecological problem can be a mechanical problem related to the pelvic floor and its integrity, any physical insults there have been to that, for example, childbirth. But equally, it can be influenced by malfunctions in the peripheral nervous system, and in particular, problems within the cord at the lumbosacral level, or what we call the conus medullaris. So, lesions to the cord at that level can affect bladder control, bowel function. If you don't have sensory information coming back that allows you to maintain pelvic floor tone, that then can manifest as mechanical problems with the pelvic floor. So there's a vast range of possibilities, and it's very, very difficult to be sure on that information. But yeah, if you've got cavernomas in the region of the conus, then it's definitely a possibility. With regard to the scoliosis and those are disc bulges, by the time we get to 50, half of us have bulging discs on an MRI, and most of us are asymptomatic. By the time we reach 70, 75% of us will have bulging discs, and the reports of the MRIs get more and more alarming and lengthy. But it doesn't, less than 5% of people ever come to having surgery for that reason. So it's not necessarily an indication that one ought to go looking for things in the brain or spinal cord. And I think the clinical context is very important there.
Excellent, thank you. So Mr. Walsh, you've got 10 more questions. So I'm thinking we carry on, if it's okay with you, till 9. But I think at that point, it's only fair to let you go. It's getting quite late. So the next question is, thank you a lot for your talk. I had a bleed 7 months ago. My surgeon says I can still do the surgery fine. Do you think it's still smart to operate even now, so even 7 months after the bleed?
Is this a spinal cord cavernoma?
They don't clarify whether it's spinal or brain. And actually, they've just said in the chat, because it's Florence, she said, yes, it is spinal.
Yeah, so as you saw from the data I showed, the results of surgery tend to be at their best when the surgery is within 3 months of a bleed. But that doesn't mean it's necessarily impossible to do, or might not even be a good idea to do. And that's about as much as I could say without reference to the details of the case and the imaging. As you saw, some cavernomas will present to the surface in a way that makes them accessible. I can see there's no risk with the scarring. You will never get a neurosurgeon worth their salt to say there's no risk to anything. And yes, the scar that develops around healing around a cavernoma probably does contribute to somewhat poorer results for people having late surgery, because the presence of a blood clot around the cavernoma creates a natural space. It does all the damage. The surgeon can then travel through that space and not be blamed for the consequences, or not make them any worse than they already are. But if the surgeon has to separate the cavernoma from healed tissue, then there's probably more risk of disturbing that tissue. But as I said, depending on where it's located, that may be a reasonable risk on the balance. So, and when I say where it's located, where it is exactly in the spinal cord, is it contained within the spinal cord, or is it presenting to a peel surface? If so, which peel surface? If it's presenting to the front of the cord, that's going to be considerably riskier than if it's bulging out the back.
Thank you. So we've now got questions about spinal cavernoma positioned in the C3. So one question is around the typical symptoms, and thank you to Florence for positive feedback. She appreciated what you said.
Welcome.
And then the other one is, again, C3, whether there's any correlation to breathing issues with the C3 intramedullary cavernoma. And she said, as it was alluded to nodule in area and breathing issues. So yes, question about that.
So the segments of the spinal cord at C3, 4, and 5 give rise to something called the phrenic nerve. And that nerve is what makes your diaphragm go up and down, which is a very key element of effective ventilation, filling your lungs. It's not the only driver of ventilation. You also need the muscles, what we call accessory muscles, which are, for the most part, include muscles around the ribs. So those range from the cervical segments all the way down to the lower thoracic ones. So when you ask, can a cavernoma at C3 be associated with breathing issues? Yes, it can. But it's not necessarily the explanation, depending on what the nature of the breathing issue is. So not all breathing issues relate to paralysis, for example, of the diaphragm or poor ventilation. So I couldn't really be more specific on that.
Excellent. So the next question I think we've answered, which is, do cavernomas keep enlarging? And you've talked about the extent to which they can get bigger and smaller.
Mm-hmm.
The next question. I have a spinal cavernoma at C1, C2, and I had surgery in 2017 as I had a bleed and a clot. The clot was removed, but I still have the cavernoma. After a year of full-on rehab, I was walking, jogging, playing sport again, but I still had sensory coordination balance issues. I also get significant nerve pain in the back of my skull. Do you think this could be the sign of a brain cavernoma, or from the damage caused from the bleed to the nerves at the time?
Mm-hmm. So as we said, if you've got a spinal cord cavernoma, there is anything between a 10 and 40% likelihood of having a brain cavernoma. That, of course, does not mean that that's the reason for those symptoms. And you can absolutely get neuropathic type pain arising because the nerves that run up the back of your scalp here arise at the top of the cervical cord as well. And then they run up right to the top of the head here. And so the feeling and this whole area can be affected not only by hemorrhage in the cord of that area, but also the surgery necessary to reach that area. Most patients, when I do surgery in that area, will experience an area of loss of feeling or sometimes unpleasant dysesthetic pain for a period of time afterwards, which gradually gets better. But if there's an injury within the cord, then that might be more permanent, unfortunately. So it's quite likely it's related to the original disease.
Thank you. So a broad question here is, what causes cavernomas? And I'm conscious that's quite a big question, but maybe if you could just summarize briefly.
Well, we're not entirely sure. Something happens in the course of cell developments who are probably destined to be blood vessels in the great plan, but something diverted them, and they end up as rather unsuccessful blood vessels in that they're connected to your circulation only by very small blood vessels and themselves, so they don't get a lot of blood flowing through them, which is one of the reasons they're not likely to cause big hemorrhages. And we know to a degree that it may be under genetic influence for some people. We know things like radiation can cause cavernomas to develop, but for most people we see with cavernomas, there really isn't a history of any of those things. There's no family history, no history of having cranial irradiation. If you had, say, a brain tumor as a child, that was successfully treated, that might have involved irradiation of both the brain and the spinal cord. And in those folks, later in adulthood, you will sometimes see cavernomas develop. But for the majority of people with cavernomas, we don't identify a link like that. The Issam Awad, who I think has spoken to you in the past, has done some experiments with pigs who have um, genetically induced cavernomas, and when they're born, you don't see them on the MRI necessarily, but if they're allowed to mature, you will see evidence of the blood leaking out of them, causing the hemosiderin on MRI over time. So it's the leakage of blood from the cavernoma that makes them visible to us on scans, even though the lesion itself might be there within the tissue.
Mhm. And just to that person who's asked that question, if you go on our website, we've got some leaflets which go into more detail about this, and there's some good blogs from our former scientific advisor, David White, who's actually been on this chat today. So the next one, could it be that one who has developed CCMs in the brain, you could develop them then later on in the spinal cord? And can arms and legs be affected by CCMs in the brain and spinal cord? For example, a hand, arm, leg loss reduced in strength and mobility.
Yes, it's relatively common for them to be affected by a symptomatic cavernoma in the cord because there's so little wiggle room for the cavernoma to even exist, let alone leak blood. In the brain, it depends on where the cavernoma is situated, because if it's situated right over here at the front, then it's quite unlikely that even a relatively large amount of bleeding from the cavernoma, it would need to be very large to affect motor function in the extremities. But if it happened to be situated at the point where voluntary movements in the arm or the leg are initiated, then it would be entirely possible for it to do it. So it needs to be more precisely located in the brain. In the spinal cord, it's more likely to happen because of the lack of real estate for the cavernoma to occupy.
And I guess the other part to that question, they're in, I'm assuming they have familial cavernomas, so potentially have multiple cavernomas in the brain, about then going on to develop spinal cavernomas and concerns about that.
Well, it is more common in genetically linked cavernomas, but if they haven't been identified at this point, that's good. We really don't know what the likelihood is that they might develop at some point in life. As I said, the cavernomas can be present, but perhaps not visible on MRI if they haven't leaked. But if they haven't leaked and they're not causing symptoms, it's probably best not to be thinking about them pragmatically.
Thank you. So we've got 5 more minutes before I think we need to give you a break, Mr. Walsh, because we're firing so many questions at you. We may not be able to get through all of them, but I'll carry on for the next 5 minutes to see how many we get through. So I have a pons cavernoma with a DVA. Recently, I've had worsening symptoms, but no recent bleed can be seen or loss of sensory on my RHS first bleed in 2016. Where can I find a neuro team to help with systems? And would it be prudent to find out if it can now be removed?
So, because of the nature of the density of function that's packed into an area like the brainstem, it's possible for very, very tiny changes in the ultrastructure of the cavernoma or bleeding to manifest as symptoms. But when it is very small amounts, there's also quite a good chance that those symptoms will stabilize or not necessarily progress. Although it doesn't take a great deal more bleeding for them to result in a progressive disability. And over time, if one sees evidence of progressive problems developing that one can confidently attribute to the cavernoma, then that's a situation where you would give some thought to whether it might be safely removed. And that's it's a talk for another day, really, brainstem cavernomas, isn't it? It's not some of them are operable, but they all come with considerably more risks than the equivalent cavernoma in the lobes of the brain. Um, but it can be done, and it becomes a question of balancing the risk of the individual procedure against the symptoms of the individual patient, and you have to again look at it on a case by case basis.
Thank you. So next question. I'm having a cavernoma removed from C2. It's unfortunately quite large, but fortunately my symptoms are mild. If the surgeon isn't able to remove it all, is there a big risk of it growing back? And do you know the risk of quadriplegia from surgery at this part of the spinal cord? And they put, or do I want to know? And we are mindful, it can be hard, can't it, hearing all the information about the risks.
Yeah. So I think probably the person who's best placed to tell you that is the surgeon you're entrusting with your operation. You saw a little bit in my talk about the technological means we have to mitigate the risk, but I think no one will really say to you there's no risk of something horrible like quadriplegia in that location because the spinal cord, if it's a very large cavernoma, will already be thinned. And that may make it more vulnerable. But I will tell you from experience that doesn't necessarily mean it's inevitably going to end badly. And it's extraordinary. Some of the spinal cords I've seen where I can basically see through them like a wet Kleenex to the front, and yet they're functioning pretty well. So I don't think there's any reason to believe that you won't, your operation won't go well. Having a larger cavernoma in a funny sort of way will sometimes make it a little bit easier to get the dissection started from the spinal cord. Um, in terms of recurrence, yeah, I think if you can't, these things, when you take the blood out of the cavernoma, you're left with tiny translucent membranes. It's very easy to leave a few cells on the surface of the cord, however careful you are. And I think if we're honest, I usually quote about a 10% risk of recurrence, even if I think I've completely removed the cavernoma over a lifetime. And that's based on some data from Italy, where they were very, very critically reviewed their own results over about 20 years. And I think it was a really good quality paper, which certainly chimed with my experience. If you can clearly see that there's some cavernoma left behind, a sensible surgeon will sometimes say that the risk to remove it is just too great. Say the neurophysiology is telling you something's amiss. Well, you may want to accept that, but again, the Italian series suggestion was that even that can still alter the natural history of the cavernoma somewhat. Won't remove the risk of bleeding, but it might reduce it.
Fabulous. So I'm just going to do one more question, and that is about medications. Is there a certain pharmaceutical group that you have noticed that influences reducing of a spinal cavernoma in conservative treatment?
No, I don't think we've got any data on that at all. The usual candidate medicines that spark interest and that might affect the biology of a cavernoma will come to mind, whether that's beta blockers or statins or whatever. But really any effect is theoretical. And I don't think I could be recommending a medication that's likely to benefit somebody with a cavernoma in the spinal cord at the moment. Um, in terms of risk of hemorrhage. When somebody is dealing with things like neuropathic pain, then there are agents one can use to shut down the messages going to the brain to try and make the symptom a little bit more livable. And those are used in various types of chronic pain, but those have certainly got an application in symptomatic people.
Thank you very much. And Ms. Walsh, someone's just said in the chat whether you could share a link to the Italian paper. So I don't know if you might be able to do that at the end.
Yeah.
I just want to say a
I'll
huge
maybe email it to you because I'll probably have to do a bit of digging.
yes, yeah, please do, and then we can share that when we share the link to your recording. I just want to say a huge thank you. I've learned so much. I can see on the chat it's been invaluable to our members. as you've said, there's so little information out there on spinal cavernoma. So we've had people join us today from Australia, Canada, the US, it was Netherlands, Bulgaria, Sweden. I think that just speaks volumes about how important this webinar was to the spinal cavernoma community. And we're ever so appreciative of the time you've taken at the end to answer the number of questions. So thank you so much. We really, really appreciate it.
You're very welcome. And don't be afraid to talk to your local neurologists and neurosurgeons about any questions you have. You'll find them very receptive, and I'm sure most will do their level best to try and answer, but sometimes we just don't have the answers.